Hello, good afternoon, everyone, and welcome to today's seminar from a very beautiful and warm and sunny Sheffield. My name is Joe Chris. I'm from the not-for-profit social enterprise Opus Independence that coordinates the Festival of Debate. The Festival of Debate is an annual programme that we run here from Sheffield that brings different communities together to discuss new ideas that shape our understanding of the world. All of our events are pay what you feel to ensure that they're free at the point of access, but we do rely on donations from audience members to help us make it happen. If you are in a position to do so and are happy to contribute to the Festival of Debate, you can do so by clicking on a PayPal link or by contributing by visiting the festivalofdebate.com. We do have a chat open today for those of you who are watching this event in real time in the Zoom webinar. So if you have any questions or comments, please do put them in the chat. Maybe let us know what organisation you're from or where you're watching from today as well. That would be great. And if all of our panelists as well, keep an eye on the chat and you can respond to any questions that relate to your areas of expertise. That's it from me. I'm going to be in the background now, running the live stream. So I'm very excited and pleased to be able to introduce our chair for the first section of today's event. Could you please welcome Alan Walker from the University of Sheffield? So Alan, if you could turn your video and microphone on, please, that would be lovely. Thank you.
Okay. Thank you very much indeed, Joe, and a very warm welcome from me as well. As you heard, I'm going to be chairing the first session, which is on display now. And let me just say that this is the second session run under Festival of Debate. The last one was focused mainly on disability and a new progressive vision for the care of those people with younger adult age with disability. And this one is going to focus on later life. So a new and progressive vision for social care in later life. And it's split into two sessions and we'll have a 5-minute break between them. And there'll be time at the end of each of these blocks of presentations by experts to have a panel discussion with questions from you if necessary, but there's also a formatted question that is presented at the bottom of that slide. Okay, so we aim to finish by 4, as I say, with a 5-minute break. So Joe, if we could move to my slides, I'll push on. Back, if you will. There's a previous slide. Joe or Natalie, thank you. So I've been researching the field of social care for older people for more than 40 years. So I'm going to start with a very personal overview, which should provide some background for the rest of the debate. So if we go right back to the beginning of the welfare state, social care was always an afterthought. It used to be called the personal social services. And it was an afterthought because in a liberal, familist society like Britain, the services provided personally were considered to be the responsibility of the family. And it wasn't the role of the state to intervene at all. Well, of course, the state did need to intervene because some people needed care and they didn't have families. So over the early life of social care, there was this constant debate between community and residential care. And as you can see from this presentation, famously, Peter Townsend in the early 1960s investigated residential care, which was mostly large institutions in old workhouses, very paternalistic regimes, and stigmatized, therefore. So the residential home was the last refuge. Then the debate shifted to community because of the critique of residential care. And then the discussion was, do we mean care in the community or care by the community? And of course, the government wanted care by the community, whereas those representing older people wanted care in the community provided by social services. When I looked at this first in the early 1980s, I concluded that there was no such thing as community care. It was and actually remains care by families, and within families, it is overwhelmingly still care by women. And then the debate shifted because of the cost implications of increasing residential care to aging in place. How can we keep older people in their own homes for as long as possible and avoid residential care? Next one, please. So I was asked in the mid-80s by the local government association to review community care for older people. And just looking back for the purposes of this webinar, I was struck by how contemporary my conclusion was. I apologize for the self-reference and apologize for the old usage of elderly people rather than older people. But I concluded back in the mid-80s that there was a crisis, and it wasn't caused by growing numbers of older people, but it was caused by the fact that the then government was withdrawing resources from social care in particular. And it was withdrawing resources at the same time as the need for care was rising. Next one, please. Now the care gap has continued to widen, and it is widening as we speak. On the one hand, as you can see, there is a growth in need. That is those people who are experiencing difficulty with at least one activity of daily living, ADL. And particularly the expansion of very elderly people, 85 and over, up to 50% who have frailty. So need is rising. But on the other hand, there are severe shortages of the supply of social care. Just a reminder, in the first bullet point under supply, the majority of older people receiving care either get it from themselves or family and friends, or they have no help at all. And that remains to be the case. And as you can see at the bottom bullet point, the National Audit Office has pointed out that government funding for social care fell by over a half between 2010-11 and 2019-20. Next slide, please. So as a result of the shortage of resources since the 1980s, it must be said, social care has always been tightly rationed. So go back to the 1970s, around about half of older people assessed as having moderate need, the moderate level of need for care, received home help support funded by local authorities, sometimes with means testing. But today, none of those with moderate need get support. It's only those with substantial need. And because these services are provided locally and funded sporadically, we find there is a significant variation and unevenness in the supply of care between different areas. That means that an older person with the same level of need in one place will get a very different level of care to someone with the same level of need in another place. Next one, please. Now, I put this slide up to serve as a reminder that older people are not just the passive recipients of care, they're also the active agents in their own care, because most care is self-care, but also, as you can see from this slide, in providing care to others. At the far right-hand side, that is usually for spouses. Next one, please. And in this slide, I tried to summarize why social care appears to be in a constant state of crisis. So It was never rescued from its Cinderella status. It was never put on the same level as the National Health Service. There's always been a presumption that families can care. That's never been fully challenged, and it's often reinforced by certain racist assumptions. I've heard, for example, providers say that, oh, people in the Chinese community look after their own older people. They don't need support. Cost efficiency has always been given precedence over care quality, especially in the 1980s in the privatization of residential care. But actually you can track that all the way through to the present day. Aging in place as a goal was never properly funded. Sufficient community resources were never provided to enable people to live independently in their own homes with support from social care. The need for risk pooling to fund social care like the NHS has been avoided for decades, and it will probably go on being avoided, even though we're promised a white paper on the funding of social care. The social care workforce has never been adequately trained, paid decently, or valorized. Apologies for the typo there. Prevention and rehabilitation has never been prioritized. Once, far back in the history of residential care, there was some rehabilitation, but no one comes out of residential accommodation rehabilitated these days. And there has never been a long-term vision. In short, social care has never been a political priority. Next one, please. And that point was summarized in a recent report by the National Audit Office that came to a rather damning conclusion that there's a lack of vision, short-term funding, meaning that local authorities can't innovate, they can't plan for the long term, and investment in accommodation and the workforce has been constrained as a result. Next one, please. So I think all of those failures, stretching long back into the past, inexorably bring us to this current graph. The recent austerity policies and deep-seated ageism, all of them are demonstrated in this horrific death toll in care homes between 2020 and 2021. Mostly in the two waves that you can see, with COVID driving up, not just those deaths that can be related directly to COVID, but to other causes as well. Some 40,000 older people who are resident in care homes have died over that period. That is a truly horrific death toll, basically as a result of the failure to protect care home residents. And you've heard since the Dominic Cummings statements in Parliament, many excuses offered why this failure to protect care homes and that nonsense of a protective ring being put around care homes in the first wave, not even in the second wave, as it happens. But I think the key factor underlying this, and much of the low status of social care for older people, is basically institutional ageism. And if you show the next slide, please, Natalie, I've argued this in a recent blog, that there are immediate factors that explain the low status of social care for older people, but there is this underlying notion of ageism that we should not be investing significantly in a population aged 80, 85 and over. Okay, so that's my quick run through by way of background. Thank you very much for listening, and thank you, Natalie, for taking us through the slides. It's my great pleasure now to introduce our second speaker. That is my good colleague, Professor Sue Yendall, who's Professor of Sociology at Sheffield University and the director, the founder and director of Circle. That's the Centre for International Research on Care, Labour and Equalities. Over to you, please, Sue.
Thank you very much, Alan, and thank you everyone for coming along to listen and to participate in this very important debate, which I'm very pleased to be able to contribute to. I've called my short contribution Into the Future, a positive vision for adult social care, but I must say that Alan's painted a picture which really provides an excellent background to what I want to say, and I agree with every word that he's said, based on also my many years of studying this topic. Adult social care has been described as stuck in the past. Indeed, in the publicity for this very event, that was a term that was used. And frequently, I think many of us feel that it's got stuck in a permanent crisis. Many people working in the system and some of those who decide to leave it, particularly in home care, I think feel that the system is letting people down. And in my worst moments, what I fear is that we're moving towards a two-tier system where we might be able to provide really rather good care for those wealthy enough to be able to afford to pay generously for it, but that most people will have to make do with something very substandard if they get anything at all. And that's something that I think we all want to avoid. Now, as Alan's already mentioned, when the NHS was established in 1948, the importance of social care, and I define social care as support to live well in daily life, whatever your age or abilities, support for that and its importance was not well understood and was not planned for. Now, of course, the NHS has been vital in giving us longer lives, but inevitably as we survive critical illnesses and chronic conditions and accidents of various kinds, many more of us live lives affected by complex conditions and impairments. And it's in this sense, I think, that we can say that care emerged in the mid-late 20th century as a new social risk, and that over the past 70 years, care has gradually become, in the way that Alan has described, a marginal and still weak and limited, but in fact a social right. And that's the area that I think we want to emphasise and to press on. Much progress, of course, has been made, and Alan's mentioned the transformation of institutional care. And I remember that very well as a young woman in my first job. Before I started university, I worked in what was then horrifically called a mental subnormality hospital, where I worked as a nursing assistant on a ward for children with disabilities. And I shall never forget the shock I had when I saw the way in which they had to live. And we must never return to anything remotely like that. We've invented supported living, which has been a great development. We've decided that we must focus on personalised and dignified care, which is a really important move forward that was made some 20 years ago now. And in 2014, we passed a new piece of legislation, the Care Act in England, focused on wellbeing and prevention. We've decided that it's important that we respect and support unpaid carers, the families and others, neighbours and friends that Alan was speaking about a moment ago. And we've decided that choice and empowerment are the societal goals that we must reach for regarding disabled people. But things have, of course, gone badly wrong. And as the situation that Alan describes is absolutely correct. And COVID-19 has now made all the worst features of adult social care and the things that are wrong about the way it's resourced and funded and planned for and provided horribly visible to all of us. I think we would agree that central government has failed to put adequate resources in place, and that's a fundamental issue. Local authorities have consequently faced terrifying budget cuts. Alan's mentioned those as well, of course, unevenly spread across the country, when investment is in fact what was needed, not cuts. And great ideas, direct payments, personalised budgets, personal assistance support have been implemented in ways that in fact curbed and stifled their transformative potential rather than enabling them to actually deliver on their promise. Consumerism and market power and market choices were invoked as the changes and new values that we needed, when in fact what was actually required were flexible, accessible, reliable and timely personalised support, adequately funded and in a stable manner. So there is an awful lot that we need to change. So for local communities to deliver caring and effective support, I think it's important to recognise that there does still need to be an enforceable framework of national standards. And most importantly, I think it is vital that central government does its job. And in the first place, it needs to prioritise funding reform and the provision of adequate funds. And in the second, it needs to loosen its grip, allowing local choices and priorities to drive change. But national standards will need to be raised regarding the following. First of all, people's rights to support. Those can only be guaranteed, I think, at national level, and that's vital. We need to address the parlous situation of the care workforce, which has been bad and deteriorating now for decades. We need to address job quality, employment rights, career prospects, and to recognise the specialist skills that are involved in providing care to others, particularly in advanced old age and with some of the conditions that and multi-morbidities that older people may have. And we need a national commitment to working to create enabling caring communities that encourage the emergence of flexible, supportive networks and ensure that no one is left to care or to live alone, exhausted, fearful, or depressed. Controls of the extraction of profit from care services are also something that I would like to see national governments address. But with those standards in place, what can local communities do to create a caring society that embraces all, leaving no one out? Well, here are some of the things I think would be important for a local approach. Strengthening volunteering and voluntary action. But that will need enhanced support, not just enhanced funding, although that will be vital, but also more information, better flows and communication between statutory services and what volunteers and voluntary action can achieve. And I think probably we need to start planning for that on 5-year cycles, both in terms of investment and of delivery of what's going to be provided, rather than the year-on-year funding that currently exists. We need to create connections and links between care and support services and small care businesses, including tech providers, so that they work together well, they cross-refer, both those they're looking after and supporting, and offer joined up support. We need also to learn from successes elsewhere, and there are many of these, not only in the UK, in England, Wales, Scotland and Northern Ireland, but also around the world. We need to think about developing dementia-friendly shops, cafes and leisure facilities, and some of this, of course, has already started, but it needs more investment and more resources. We need support to access welcoming open spaces, parks and gardens. We need, again, as others have done, to think about adapting living environments so they really work for older people and those with physical impairments and mobility difficulties. We need neighbouring schemes that will combat isolation and loneliness by linking generations and providing timely and practical support. We need effective and prompt connections between services, and we need home care support that's in a continuous two-way dialogue with primary care, with occupational therapy, and with tech services, and of course, with people being discharged from hospitals and in the weeks and months that follow that. We need re-ablement services that focus not just on the person and enabling them to perform specific tasks, but that enables them to reconnect with their networks, with the activities they enjoy, and with the values and choices that they themselves would want to make. We're going to need, I think, to create care and support planning teams at local level that can help people think ahead and prepare for the inevitable changes in advanced old age and at the end of life that they will face, and to help them to make and to express their own choices and to achieve their own later life goals. Now, I think all these things are important, partly because not only have I studied this subject for many decades, but I've also, of course, experienced the ups and downs of life and family situations across the years that have gone by. I have a sibling, my sister, who now has advanced MS, which she's had now for well over 35 years. She's been supported at home by her husband, so I've seen the caring that he can provide, and by teams of carers. And in Northern Ireland, where she lives, that service has been free and it's been delivered to her in a compassionate and caring way, which has made a huge difference to her quality of life. I have a father who was almost 100, who is living independently at home, but I see his increasing frailty and I see the difficulty that he and I are experiencing in trying to get the right help at the right time, in the right way, in a way that is acceptable to him and that is kind and supportive and ready when he needs it. In what follows, my colleagues, Professor Matt Bennett and Dr. Kate Hamblin, who work with me in the Circle team at the University of Sheffield, will next speak. Matt's going to talk about some of our work on unpaid carers and the costs and consequences that they face and their experiences in the pandemic. And Kate's going to talk about her work on care and technologies, sharing her insights about how technology can be a tool to help humans provide better care. But I want to end with one final comment. Good care and support allows people to be themselves, to participate in chosen activities and to be supported, whatever their bodily or mental capacities, with dignity and compassion. It enables them to live well and in harmony with their own culture and values. But it's not rocket science. We can do it. We can create caring, empowering communities for all. Thank you very much for listening.
Thank you very much indeed, Sue. And thank you indeed for introducing the next speakers as well. So I won't dwell overly on that, but I'm delighted that your colleague and my colleague, Professor Matthew Bennett, is next in line to speak. And as Sue said, he's a co-investigator at the Circle Centre. So Matt, please.
Many thanks, Alan, and many thanks, Sue. I think there's a great contextualisation of adult social care at the outset from Alan. Particularly thinking about his comments on sort of care happening in the community, and I think that this is, this now, the work that I'm going to be sharing sort of demonstrates the impact of those people in the community, unpaid carers who are providing so much support for loved ones and some of the most vulnerable people in our society. But also the contextualisation and the recommendations outlined by Sue. I think it's when we have that contextualisation of the system and what recommendations can be made and what needs to urgently be made for urgent reform, it helps us to understand some of the findings that I'm going to be sharing with you now. So I've been working for a few years now with Sue in Circle and on sustainable care research, and I've been mainly focusing on the costs and consequences of unpaid care for those people who provide it, particularly thinking about financial costs and consequences, health outcomes, and social relationships and social isolation and loneliness in particular. What do we mean when we think about unpaid carers? Well, we're typically looking at people who look after and give any support to anyone because they have long-term physical or mental health conditions or illnesses or problems related to old age. And I think as well, one of the things that I wanted to highlight as part of this ongoing work is the relationships that we have with people in the sector and charities and stakeholders, really co-producing research to help us understand the inequalities of care and to help us make informed evidence-based decisions on how we might go about supporting unpaid carers. So I just wanted to reflect really on some of the work that we've been doing with Carers UK in partnership with the Sustainable Care programme. We know from the broader academic literature that there are huge inequalities and that care carers suffer as a result of the care and the support that they provide, and that there are massive gender inequalities too. So in a report that we published in 2019 with Carers UK, we basically looked at the social profile of carers and who was more likely to care and what this meant at different stages of your life course. And we found that 65% of us will provide care at some point in our lifetime, and that's a higher likelihood of owning your own home. Women are more likely to care than men are, and they are more likely to provide the highest intensity of care too. Women become carers 11 years earlier than men do, and we also know that there are huge health inequalities as a result of being an unpaid carer as well, and also significant financial implications in terms of labour market participation, pension contributions, assets and savings, etc. So in the context of these inequalities, at the outset of the pandemic, as a group, we were really interested in looking to see what the impact of the pandemic was having on unpaid carers. We have a number of reports that you can find on our website which describe this research in a bit more detail. So I was really interested in mental well-being of unpaid carers, also hunger and food bank use, and also social isolation or loneliness as well. So just thinking through some of these findings, just more broadly, we found that carers' mental well-being was lower than non-carers. We found that females had much lower levels of mental well-being than male carers. And that it was also lower for working age carers, especially those in the 17 to 45 year category. We also find that there were significant declines over time. So carers experienced the strongest decline in their mental well-being just before the pandemic and going into that the first few months of the pandemic. And females experienced the biggest decline in their mental well-being too. Older carers also suffered a decline in their mental well-being, and it also declined for carers in employment and carers without a paid job too. In terms of hunger, we found that 3.5% of carers said that someone in their household had gone hungry in the previous week, and this amounted to approximately 228,000 carers across the UK. Females were more likely to report this than males, and also younger carers experienced greater levels of hunger compared to older age groups. Quite shockingly, carers were twice as likely to report using food banks in that first in the first few months of the pandemic as well. Just over 100,000 households with carers in it had used the food bank in the previous 4 weeks, and again more likely to be women compared to men, but also 8% of carers, or younger carers aged between 17 and 30, were more likely to rely on a food bank as well. In terms of loneliness, we found that about 30% of carers reported being lonely in the past 4 weeks. 1 in 3 women who were carers reported this versus 1 in 4 males. So again, a strong gender gradient there. Carers in younger age groups were more likely to experience feeling lonely, and also working carers as well. And so I think it's important that we found that a number of these inequalities had been exacerbated as a result of the pandemic. That a number of these inequalities that are well documented in the literature just widened. So, one of the things that I think is really important to stress, and that Sue has already discussed, was that there were already inequalities and failings before the pandemic. They've just been exacerbated now, and they've raised the profile of care and unpaid carers too. So women were more likely affected, across these well-being measures. So I think it's important as a society, and particularly at local levels, how we think about how we support unpaid carers. So thinking short term of ways that we can end carers' financial hardship, ensuring that systems are in place so that carers can access food, and that there's increased investment in their mental health and well-being support for carers. Making sure that services and the provision of services are better supported and reinstated. Particularly things like respite care. And in the long term, really thinking about how we increase recognition and identification of unpaid carers, and the financial, making sure that they get the financial support that they need. Making sure that social care is a priority for funding. That it's receives parity with the NHS, improving carers' rights in terms of things like being able to make them better be able to juggle their work and their caring responsibilities, and really just making sure that the needs of carers and those they support are fully considered throughout throughout our recovery plans and moving forward. So those are the main topics and issues that I wanted to discuss, really focusing on some of the empirical work that we've been doing as a group. I think shortly we're going to have an opportunity to discuss what these might look like in a bit more detail. So thanks very much, Alan.
And thank you indeed to you, Matthew. Very grateful, as you say, we'll be able to come back into discussion Q&A session. But next up is another one of our colleagues from Sheffield University, Dr. Kate Hamblin from the Circle Centre that Sue and Matt are also part of. So Kate, please make your presentation.
Thank you very much, and thank you for asking me to be involved, and the great presentations we've just had as well, which, as Matt says, give a really great context to what I'm about to talk about. And what I'm going to talk about is about technology, but really I'm going to talk about people, because it's not really about the gizmos or the gadgets or the whizzy bits of kit. It's about the people that use them, the people that are connected by them, the people that make them work. And I want to talk about where we've been, where we are, and where we might go with technology and care. So in terms of where we've been, technology and care systems have always been a tool or a facilitator for what are very human caring relationships. And they've always been highly reliant on people to make them work. So if you think to the classic pendant alarm, which has been around since the 1960s, they're ubiquitous. 1.4 million people in the UK have one. They really haven't progressed technologically since they emerged in the 1960s. They're very simple mechanically. They rarely fail mechanically, but as a service, that's where things can start to go wrong from the perspective of the user. So in work we've done, we rarely heard people say that they pressed the button and it didn't send the signal to the response box. They would more likely report that where it went wrong was around the assessment or the installation or the way the call was handled or the response service. So people there are really integral to these technologies working. But yet often these people are invisible. So, for example, during the pandemic, the Technology Enabled Care Strategy Board, which is the representative body for these services, had to lobby government to make sure these people were included as key workers. So they would have access to PPE, access to childcare, because they were invisible, because the focus is so often on the technology rather than all the services around them that make them work. And policy is incredibly technocentric and device focused. And as another example of where it's focused specifically on the kit rather than what makes the kit work, if we think to Matt Hancock's promise of 10,000 iPads for care homes during the pandemic to replace what were deemed unnecessary in-person visits or dangerous in-person visits, that didn't factor in the fact that 1/3 of all care homes do not have adequate Wi-Fi. So 7,000 care homes don't have adequate Wi-Fi. And it doesn't factor in the other end of that. So with an iPad, you can do Skype calls, for example, to people who are not able to visit you anymore. But do those friends, family have the access to those similar devices, Wi-Fi, the skills to connect. It just was a very technocentric approach to an issue that was essentially social, a sort of technological sticking plaster that didn't actually adequately address the real issue. But nonetheless, technology is a key policy area. We've seen it in the recent white paper on social care. And technologies are getting smarter and are able to do more. They're able to be more predictive and preventative. And they almost need to be, actually, because we are going to see the switching off of the analog systems that a lot of the traditional telecare is reliant on. So we're going to need to move to digital. Are they going to be digital pendant alarms, or are they going to be something a little bit cleverer almost? And we've seen examples in our work of where local authorities and other organisations are exploring these more preventative and predictive pieces of equipment. So you've got, for example, the armed system, which can record people's sleep patterns and mobility patterns and use that with predictive analytics modelling to alert when they're at risk of a fall, rather than a very reactive system picking them up off the floor when they have fallen. However, again, these types of technologies still require people to use that data and information and then take action that can prevent an emergency taking place. So technologies have been deployed in adult social care to keep people safe, but they have to involve people. And they were very traditionally deployed to do this, to manage risk around ageing in place. And that, to some degree, had some unintended consequences because of the way these technologies function. They are very place specific, so they don't really enable people to travel further afield than their homes. That, you know, increasingly that is possible, but pendant alarms can't really do that for you. And I think we, as a society, and also policy wants more. If we think about the Care Act that Sue referenced, well-being is in there. We want well-being, we want a good life, we want happiness. And in our work, we've been thinking about the ways care can be organised to deliver on well-being, and included in that is the way technologies can help deliver well-being. And we think about well-being as being a multidimensional concept. So we think about how materially what people have can contribute to their well-being, and certainly some people can be excluded from the well-being effects of things like technology if they can't afford them or afford access to the connectivity to make them work well. So we've seen examples of local authorities not just providing equipment, but actually providing the connectivity that people need. So there are examples of local authorities investing in 5G mesh networks and LoRaWAN networks to provide that free Wi-Fi connectivity to people living there, to then enable them to use digital devices to support their care needs. We've also think about the subjective well-being, so how people's sense of self is affected, and we certainly know that pendant alarms don't necessarily bolster a very positive sense of self. They carry a degree of stigma. They're generally not worn with pride. And perhaps the move we've seen in some local authorities towards more mainstream devices can address some of that, because these devices do carry less stigma because everybody has them, sort of thing. But the area I really want to focus on is the relational well-being, so our social relationships and how technology can contribute to those. So a colleague of ours called Annie Austin took relational well-being, so relationships, that step further to think about good social relationships and how actually that is fundamental to a good life, and that care is a fundamental part of sociality and good social relationships. And thinking about how technology can contribute to sociality and good social relationships, we've certainly in the project observed how COVID-19, though it has been undeniably terrible, it has actually accelerated the use of technology for this purpose. For example, we're here now today at a festival on Zoom. I'm sure we've all used Zoom in our personal lives in ways that perhaps we hadn't before, to, you know, quiz with family, or I've used it to attend baby music classes with my son, something I definitely wouldn't have done prior to the pandemic. But if we look at what local authorities have been doing with technology to enable people to connect, for example, in Hampshire, where they have 53,000 people on their shielding list, with the staff they had available to call those people and find out what they might need to support their well-being, it would have taken them 6 months to do that. And that's just not practical. So they worked with Amazon Web Service to develop an automated well-being call service, which made 2,500 calls a day to ask people how they were feeling, whether they needed support, and when they'd like a follow-up call. And those who asked for help were then put forward to a human contact centre who could then mobilise that support. So it was things they could help support people to access food parcels, prescription delivery, but also the more social things like befriending services. And Hampshire describe it as trained call advisors played the part that only a human can. They empathised, discussed options and connected residents with support. And they used the system 4 times during all the various lockdowns and made over 185,000 calls to 70,000 people. And 4,000 of those were then passed on to that human contact centre and connected to the right sorts of support they needed at that time. And similarly, there's another system in place in Carmarthenshire where they adopted the Barcelona model of telecare. So whereas in the UK, it's very common for it to be a reactive service where you trigger an alert and a response then follows. In the Barcelona model, it's more proactive. So calls are made inbound to the home to see if that person needs any support. And before the pandemic, they were contacting 3,500 people regularly to check on their well-being and had linked them with appropriate services. And during the pandemic, this increased to 18,500. And these people were given access to a well-being worker to provide them with a personalised well-being plan. They were supported by community connectors to link them with activities, including in the third sector, and provide them with additional technology, such as bespoke tablets. And there was a platform to host online activities. So there were online day centres, online karaoke clubs, the sorts of things that people were wanting to do in person but couldn't do during the pandemic. And I think these are just good examples of technology being used to connect people and facilitate caring and sociality. But of course, we can't give technology all the credit because it's about mobilising and connecting people. And I think the importance of people in these technology systems has never been more apparent than during the pandemic. It wasn't just chatbots, it was chatbots and then a personal response that was the most appropriate thing that people were receiving. I think that's what technology is when it's at its best in care. It's not a panacea for a system that's in crisis. It's not about replacing human touch and human relationships. It's a tool, it facilitates sociality, and it can sustain and shape and maybe even in some cases create social networks and relationships, but ultimately it can never completely replace them. I think that's what I'd like to conclude on.
Thank you very much indeed, Kate. That was great. And we're going to move on now to our last speaker in this session, and that is Dr. Anne Hollows, who was previously Principal Lecturer in Social Work at Sheffield Hallam University. So Anne, warm welcome.
Thank you, Alan. And thank you for all the other contributions, which have been fascinating. I've been butchering my script as I listen to what everybody else has said. I'm speaking as somebody who's been involved in social work since 1972, quite a long time, but also as someone who has been a home-based carer for my late husband, who developed Parkinson's disease and ultimately spent the last 10 years of his life in care. And for my mother, who died recently, he was 96 and had dementia. So I have had a range of those experiences. I must say my professional involvement has been more with children and families, but there are things we can learn from that too. I want to start with taking you back to about 1978 when I was a hospital social worker in Scotland. And this showed really clearly to me how health and social care were interdependent, but not the same thing at all. When we wanted to discharge someone from hospital, we used to have a week's notice and we would assemble a team of OTs, physios, a social worker and possibly a community nurse or health visitor, and we'd take the elderly person home to assess exactly how well they could manage and what was needed to enable them to have a successful discharge from home and an independent life. My neighbour in Sheffield runs the part of the home care service for Sheffield, and she tells me that now she gets a phone call that someone is being discharged tomorrow, and this is the broad picture, and can she put in services? The result is usually disastrous. And very quickly, that person who is so long to get back to their own house goes back to hospital because they fall or something else fails. And I think it's this interdependence of professionals that is actually crucial to making social care work. Apart from that, of course, there are all the issues about the way in which social care is organised, which all comes down to funding, that normally the service is only for 6 weeks, and it's delivered by a whole variety of care workers attending at a variety of times. So you find that maybe a care worker will be arriving at 5 in the evening to put someone to bed when they haven't had their tea. And some people end up, those who can, end up resorting to paying for care themselves. Other people manage, as both Alan and Sue have pointed out, with very inefficient or no care at all. When my late husband was in hospital, there was a point where the senior registrar in neurology looked at me and said, "You're a professional person, you're an academic. They're going to want you to give up work to look after him. Don't let them, because you can't do it." And that she argued my case and I argued my case. And eventually he went to a very good nursing and care home. Now, that led to another issue. How do you pay? This was a man, a retired academic, who had developed Parkinson's disease and a psychotic condition that was very serious. And we were able, because I knew what this was all about, because I was a social work academic, to argue for continuing healthcare funding. Somewhere in there, in the small print, it said that there might be a review at some stage. He spent 10 years of his life in that nursing home, and the weekly cost was somewhere between £1,500 and £2,000 a week. That's the ballpark that we're talking about. After several years, the first review took place. I was absolutely terrified. I didn't sleep for weeks, waiting to find out how it would work. We were lucky. I knew how to play my answers. I helped the staff play their answers to make sure that he had sufficient severe categories to get the funding. But not everybody else was successful. And what happened to some people was that they found that the care they'd received in this care home had actually ameliorated their condition so that they didn't need funding anymore, so they'd have to leave. Now, that sort of thing coming from the bureaucracy that is health and social care is neither healthy nor is it social care. I want to move on to look a little bit more at what some of the points that have been picked up already. Certainly, there's lots of advantages of technology, but thinking about my very elderly mother, technology is only as good as the person who can use them, and she couldn't. The basic press button thing was her lifeline. She could manage that, even if she did go on to believe that the man from the Lifeline service was camped throughout January in her back garden, so he could come every time she pressed the button. And I think that the other thing that we've learned is that isolation in the pandemic has been of particular difficulty for many elderly people. What they wanted was real life people. They wanted the warmth of human contact. And I was rather alarmed to read that in a German study, they were looking at the potential of occupational activities being delivered in the form of bingo with Alexa. And that was not something that I felt we could promote. On the contrary, there are some advantages of increasing automation that are apparently going to reduce employment opportunities for people. We've heard much about the one-way traffic between care home workers and the much better paid jobs in supermarkets stacking shelves. Maybe there's a possibility that the computer systems can stack the supermarket shelves and the traffic can go back in the other direction. Care deals with vulnerability and increasing dependence and recognising the person beyond the frailty. And I just want to spend the last few minutes of my talk looking at some of the ways in which effective social work practice can respond to this. And this is based on some research and development materials that have come from Bristol University. The first point that social work can make is in understanding relationships and using a very poignant case of a couple with different kinds of deterioration of health and mental status. The social worker in one of the vignettes responded in this way. She said, "I think I see them as being devoted to each other." And then she said, "But not all couples are devoted to each other." But if you've got a case like this where they're so devoted to each other, I think that has its own specific problems because of their reliance on each other. And how do we factor in those points as we plan social care? Equally, plan care for people who are not devoted to each other. Another social worker said that we need to think what we might want for ourselves. I think I would like, if I was in that position, that the social worker demeanour, I would like warmth, communication. I would like to know that she understood. Her voice, her body, her attitude. And I wouldn't want her to come with a message of changing things at that point. I'd want the relief that someone understood, but I wouldn't want the thought of drastic change, of moving out, or the life that I've been used to changing too much, because I still want my previous life. Social workers also can help people to deal with the hardest question. The social worker has the skills both to pick up on the cues and the clues that it is time to talk about end-of-life care arrangements and to create the right environment for open, sensitive discussions with the person and, where appropriate, with the family. So the service options that might enable us to move forward. Drawing on some of the work that I've done at Sheffield Hallam in relation to children's services, all professionals must have shared understandings of roles and responsibilities and communication, and they can be co-located. There are, in some parts of the country, community matron systems where a group of professionals work together and support people in the community and in care homes. There needs also to be strong management support for collaborative working, and certainly in children's services we found that whereas the frontline professionals were happy to work together, the managers one level up were not so keen. And finally, to a couple of points from learning from my work in Europe. In Spain, I've seen residential care often located on the main street, where people can come and go from the care home and can sit on the wide balconies watching the frequent fiestas. In France, in a couple of small towns, I've seen small care homes located on the marketplace. In Holland, there's a coffee shop, not that kind of a coffee shop, in the home to which relatives, friends and communities often go. The home with its coffee shop is located on the main street there too. And in Denmark and the Baltic states, social pedagogy has formed the basis of training at every level. And finally, from my varied professional and personal experience, I cannot avoid adding that this should never be an income generating activity. It is a public good, and we should be looking to some of the developments in small cities like Preston, where cooperatives for community care and residential care are combining the interests of the residents, the elderly people, their families, and the people who work with them. And that seems to me to offer a very creative way forward to the future. Thank you.
You're muted. Sorry, Alan.
Yeah, I'm on. So thank you very much indeed, and thank you for nicely completing the first panel presentations. And we're going to move on to the discussion period, which we have around about 15 minutes for. And while my colleagues are assembling, I'll just note that in the chat box, there have been quite a few comments going through the presentations. The first one, I think, is directed at me from Joy Bullivant, and she says that ageism is not the issue, but it's those who are a drain on the state, so the state doesn't want to pay for them. I think we're going to have to communicate about that, because I think the failure to protect care homes is a clear sign of abject neglect and cannot be defended in any sense. And I don't believe that if they were children's homes, for example, that the same attitude will be taken. But I suspect we're not going to agree precisely on that point. Angela Fell makes a very good point about the need for neighbourhood-based models. And I would certainly support that. And I would point out that Sheffield used to have a wonderful neighbourhood-based model called the neighbourhood support units, which were multidisciplinary units intended to provide care for older people, but also to support the work of neighbours and the care work of family members. But they proved to be impossible to sustain because of government cuts in funding. And Joy Bullivant came back and said that it's important also to emphasize social participation. That should be a right. And I think that's absolutely right too. Okay, so are all the panelists back in the room? Great. So if you unmute yourselves, Matt and Anne, then if there are any of the comments in the chat box you want to respond to, you can do that. And then we'll address the framed question for this session. So I'll just give you the opportunity to respond to any of the points in the box.
Can I just say about Maria's comment? I really think that when people are going through this continuing healthcare assessment, one of the things that you most seriously need is somebody to work with you on it, almost like an advocate. It is a baffling form, and so much hinges on getting the right examples and the right words. And it's really, really important. And I think if we could set up some kind of support for people going through that process so that they know what's happening, and they can give examples of things that have affected their lives, or that, you know, that would really help. That hand-holding, that one-to-one experience is really, really critical.
Thank you very much, Anne. Any others want to chip in?
Alan, can I just respond to the point
please.
about people being a drain on resources rather than it being about ageism? And I think what the contributor to the chat meant perhaps was, or if I may suggest, that part of the problem we have is that we have been encouraged, certainly since the 1980s, to see people who require state support outside of the NHS as somehow a problem. And this, to me, is one of the fundamental issues that, along with what I agree with Alan, are ageist resources. And we've certainly heard people saying, well, you know, isn't it mainly older people who are dying, and won't they be dying anyway quite soon? So, you know, that has definitely been said. And I think, to me, that's a profoundly ageist and entirely unwelcome kind of comment. But actually, we don't think of ourselves as owning state resources and having the right to share in them. And if we thought about the resources of the state in that way, that we want to decide how to spend our money, and we want to decide how and in what circumstances people access it, rather than thinking that somehow people have become a drain on the state, then we would have a much more congenial conversation. And while today's session has been going on, into my mind pops the thought, we used to see a lot of signs saying neighbourhood watch around different streets and where people were watching out for criminals. Well, why don't we have this neighbourhood cares? And then, a way of actually encouraging people to think this is a great place to live. It's a neighbourly environment. It's a place where people will be supported and helped by maybe their local authority or by voluntary organisations to organise care and support in ways which would enhance without replacing basic services. And there are lots of the nice additional things that can be done practically to help people live a better quality of life with disability, particularly in old age, I think can be done by neighbours. And I see the marvellous things that my father's fortunate enough at age 99 to still have many friends who help him every single week. And it makes a massive difference, not just to the practical life he leads, but to the sociality that Kate spoke about. And it seems to me that we need to take pride in neighbourhoods that care, rather than worrying about whether they're neighbourhoods where we've managed to kick out the criminals.
Thank you very much, Sue. Any other comments from panelists on the chat box? Okay, in that case, let's move to the challenging question to each of you that you had prior notice of. So you've had a chance to select your three. So what would be the three most important steps to transform social care in the UK? And Sue, since you're up and you were the second speaker, shall we come to you first? And you, what's your three?
Yeah, happy to do so, Alan. I think adequate funding has to be a top priority. An initial injection of money to make good the huge gap that's opened up between what's needed and what's provided. And then the establishment of a stable ongoing system. So that's my number one priority. But it must be more than, it must not just be the very absolute basics. We've got to recognise that this is an area of our life which is important, that we really wish to contribute to. The second of my priorities is the workforce in care, decent jobs and jobs with career prospects for care workers. I think this is vital. We're going to need more and more people in the work of care, and we need them to be feeling proud of their jobs, which many of them do already, but also well supported in their work and able to have a decent standard of living and prospects to make the contribution that many of them are well capable of making through acquiring specialist skills and sharing them with others. And my third priority is integration and connectivities, not just between health and social care. That's not what I mean on its own. There do, of course, have to be good connections between health and social care services, but across all services and all providers, so that leisure and housing and safety and refuse collection and the quality of the pavements and the streets and everything else are all connected up, and experiences of care are joined up. And that would be my third priority.
Great, thank you very much indeed, Sue. So Matt, what are your top three?
So thanks very much, Alan. Thanks very much, Sue. I agree with Sue's points on her priorities, but if I may, I'd like to sort of extend that to an additional sort of priority, really based around the work that I've been doing on unpaid carers and the inequalities that they experience. And that is really to, align some of our thinking with some of the priorities of Carers UK and thinking about the recognition and identification of carers. So I think it's really important that individuals who are unpaid carers have an opportunity to realise that that they're doing this important work. In a lot of the literature and a lot of the focus groups that we have, we know that It takes individuals about 2 years to identify themselves or really understand that they're providing care in the way that we think about these things. And in that time, there are huge health and financial costs. So if there are ways that we can identify carers at a quicker rate, we can sort of get that support, get that information to them in a speedy manner, but also thinking about how society recognises unpaid carers as well. The value of care, what it is, how it's funded, how likely we are to need it, and how we how fundamental it is to us as a society. I think some of these issues have been are more prominent since the beginning of the pandemic, but it's we've got a long way to go. And the other point is about employers as well. For employers recognizing the impact that care has for their staff, becoming a carer-friendly workplace. With such schemes like Employers for Carers, and I know something that Carers UK are working on currently is to make caring a protected characteristic, so giving it as the same footing as the other 9 protected characteristics that can't be discriminated against, things such as ethnicity, gender and disability. So those are some of my reflections on what we can do as a society to improve things.
Thank you very much indeed, Matt. Next in line is Kate. What are your top 3?
Thank you. Yeah, I'm going to pretty much build on refer to what Sue and Matt have said, but I think fundamentally we need to see that care is an essential part of our human experience. We will all receive care at some point in our lives. We all have as babies, and we're all going to give care probably at some point in our lives. It's not a case of it could be you, it will be you, or it has been you. And I think that can help challenge some of the sort of very ageist and ableist policy responses we've seen, particularly during the pandemic. The idea of that protective ring, well, they were just older adults being discharged to care homes without testing, just sort of abandoned there. Similarly, those with learning disabilities not being in a priority group for the vaccines, again, very ableist attitudes we saw. And I think if we appreciate the universal experience of receiving care, that might help with that. And in terms of providing care, understanding that we saw a real inadequacy in the policy understanding of what it is to provide care. They didn't appreciate that care workers would be working across multiple care homes and they could do social care at a social distance. They have no understanding of how to actually provide personal care for someone, clearly, with those sorts of recommendations. And I think if we recognise the centrality of care to our existence, we will value it, and we'll value the people that do it, both those who are paid to do it. The idea that it's an unskilled job, I can't believe that it's still persisting, particularly as over time we see now care workers doing complex things that nurses would have done. We see them doing peg feeding in the community. We see them doing catheter care in the community. These things are very skilled. They need to be paid and recognised as skilled workers. Similarly, unpaid carers, the fact that they receive such a paltry amount in carers allowance, the lowest of all benefits, I think we need to recognise that care is central, and therefore value the people that receive it and the people that give it, and that can help us develop the aspirations for our care system. And the aspirations are there in policy. It's just, as Sue said, we need the funding to help deliver things like wellbeing. You can't do that on a shoestring. So I think my second point is around the funding and creating the underpinning values of a care system that recognises the centrality of care. But also, when we develop a care system, we need to think about what levers we're pulling in other parts of systems that are connected to it. So if we're going to, say, opt for an insurance-based system like Germany or Japan, are we going to do what Germany's done and allow the benefit to be taken as cash and paid to family carers? Because what lever does that then pull on female employment? Does that effectively create a sort of paid but unpaid family care workforce and take women out of what they might want to do in the labour market? So I think it needs to be a system that is holistic and considers how it connects to other parts of other systems, including not just health, but how does it link up with other parts of the wider policy systems? And I guess my third point is what I made in my presentation, which is we need to stop seeing technology as this panacea or fix for social care in the crisis. And it's a tool to facilitate care. It's not going to replace or make up for the shortfall of paid and unpaid carers ultimately.
Thank you very much indeed, Kate. And then Anne, as the last speaker.
A lot of space, really. Wonderful selections of points there. There are 2 points that I'd like to just make. One is about young carers. Now, you may think young carers is a little bit irrelevant in all of this, but I remember that because my late husband was older, my daughter was quite young when she had to address some of his care needs. And he also had grandchildren from his first marriage who were quite baffled and found it very difficult to understand and tried their best to do things and help. And I think we forget young carers may also, whether they're late children or grandchildren, may have an important part to play in all this and in understanding. I think of some of the children's books that could be written to help them understand some of these things. The other thing I want to raise, just going right back to, I think it was Alan's point about not making assumptions about minority ethnic communities that could verge on being racism. At the same time, we really need to address what is going to be helpful, what is going to work well with communities. We're all white looking at this. What is going to be their view of what they need? How can we address that? How can we make sure that we don't blunder on with things that wouldn't be acceptable? And indeed, how can we engage them much more in the process? Actually, quite a lot of the poorly paid carers in care homes in Sheffield and doing domiciliary care are actually minority ethnic communities. Most, in fact, of the Zimbabwean students I trained to be social workers told me that they got into this because they'd been carers. They'd worked as carers when they first came. In fact, one of them told me, and this is just to end on a light note, that he said, well, most of us Zimbabweans got jobs for the BBC. And when I looked at him and said, for the BBC, and he said, oh yes, the British bottom cleaners. But that was where they got their experience. That was where they got their care experience. And there are still many people from Zimbabwe and Uganda and from parts of Eastern Europe, etc., who are keeping our care services going. But we need to get into their communities as well and find out how they want their needs to be addressed.
Thank you very much indeed, Anne. I think that is an excellent note on which to end this first part of the webinar. And we haven't addressed all of the questions in the chat. There's an important one from Andy Gilbert and Stefan Ball also, but we'll try to come back to those in the second tranche if we may. Right now, we're going to take a comfort break, and there's just been a couple of minutes slippage. So unless James intervenes in some way, I'm going to suggest that everyone comes back at 2:55. That is 5 to 3, if that's okay. Thank you all very much indeed. And to the first session speakers, that's an interim thanks. So Anne, you should turn your camera off, okay? And your microphone.
Hello, everyone. I think we're almost ready to start. So I think I'm waiting for the clock to time down to 2:55 on my computer. And here we are. Okay, so my name is Simon Duffy. I run the Sheffield-based think tank called the Centre for Welfare Reform, and much of my life has been involved in trying to bring about reforms in social care. So I'm going to speak for about 10 minutes and then introduce the other members of the panel that were just up, Cheryl and David and Alexis, and then we're going to have a similar panel session at the end to review the broader questions. But I thought I'd start by putting this talk in the context of this concept of it's our community, which is the kind of name we've given to this event, the previous event that we did, and other events we've got planned. And that these events are not just for the sake of events, they're really part of a strategy to see if we can bring about some significant change. And they go to the heart of the question that Alan touched on in his talk, which is, what does this mean, community? To a large extent, I would agree with him that what went under this rubric, community care, often ended up being the transfer of resources and services and personnel out of old institutional services into better services. Physically, we might think of them as in community, but they weren't really part of the community, and they certainly weren't a function of community life. And so what we're signaling by saying it's our community, I suppose, is I think our intent is that we do need to break into that third space, that there's a role for families. It is a natural part of family life that we take care of each other, but it's also impossible for families to do that on their own without support. There's a role for funding and for professional staff, although those two things are not necessarily aligned, because my work in developing personal budgets was to say to people and families, actually, this is your money, so you should be able to decide how it's shaped. But there's also a role for the community itself in many of the ways that were touched on in that first session. The idea of doing this, I suppose, thinking about the community in this different way and thinking about social care. I mean, this event is for anybody in the country, but we do have a special interest. It's rooted in Sheffield, and we do have a special interest in seeing, hey, what could we do ourselves in this brilliant city, Sheffield? Because I suppose in my work, often what would happen is when you start to talk about reform of social care, people would often retreat to different ideological positions. So I would often find that people, whether they were coming from the disability movement or from professional services or from the family movement, often people would take up highly opposed positions. But I remember bringing together a group of people actually at a meeting of the Socialist Health Association for Yorkshire in Sheffield 2 years ago to discuss social care reform. And I was really encouraged by what happened when we changed the question. When we started to say, what do we want our neighbourhoods to be like? A lot of the barriers disappeared. People could start to imagine the way in which they would like to live, and they would like support to function in ways that are much more closely aligned, I think. So for me, that's the big missing variable in a lot of the policy discussions. Angela Fell put up a note about this in the questions earlier. I think it's not because there aren't other important issues to think about, but that one's almost kind of on the map at the moment. And we constantly forget, I think, whether we're at the sharp practice end of things or whether we're thinking about things from an academic point of view or policy making, what a weird place the United Kingdom and particularly England is. It is weirdly centralised. I often observe that, Sheffield, which is a population of 600,000, has got twice the population of Iceland, a country with a fully functioning welfare state, a parliament, a constitution, a president, and 78 municipalities, which would, in Sheffield terms, be 150 neighbourhoods. We have 142 neighbourhoods in Sheffield. We actually have 140 primary schools. I don't think these two things are disconnected. People know what neighbourhood they're in. But just as Sue Yendall was pointing out, we don't say this is a neighbourhood that cares. We don't have any structures to enable caring at a community level. We don't have anything organised at a neighbourhood level. We don't have any structures for people to exercise responsibility or care. Things do happen, but we've really created a system that makes it about as hard as possible for good things to happen at that scale. And the interventions that happen by the system, by social services, even with good intentions, are really the interventions of a kind of colonial system back into our communities. People are kind of driving into communities, telephoning into communities. Nothing is really part of the community. And so we're left with the divide Alan described, which is largely families coping with negligible support and with increasing levels of poverty. Isn't it heartbreaking to hear of carers increasingly going to food banks? What kind of society have we become? I mean, I'm not so, it wasn't so long ago when food banks were just something we didn't have. Now they're a supplement to our social care system. So we're dealing with a kind of social care poverty, disability poverty, poverty for some people in old age, and certainly a system which is economically broken. And we need to address, and as some of the previous speakers said, we do need a new economic settlement. But I think we really need to look at the other structures that go along with that new economic settlement. I think that we need much greater emphasis on human rights and the right to control. At the moment, I'm working with the European Union on guidance around self-directed support for all European states. And that guidance is based on human rights. In this country, human rights don't really get a look in, do they? The United Nations actually examined the performance of this government after 2010 in the light of austerity and said it was breaching the human rights of its own citizens, particularly of disabled people and older people. And yet that issue gets no attention. So we need to think very differently, I think, about social care, I think the challenge is not merely to think about this as some technical solution that we should just go, oh, wouldn't it be nice if we had X? Academics, charities, commissions have all been kind of proposing some kind of X for a long time. But what we haven't really done is build a kind of movement to argue for X, to persuade for X, to build X in our own places now. There are things we can do now, even in this kind of broken economic settlement, even in this weirdly centralised state. There's lots of things we could do differently now. Sheffield really could just reinvigorate its neighbourhoods. Tomorrow, the council, we've got a new council and we're looking forward to finding out what that means. But that council could say, right, let's take our neighbourhood seriously. Other councils are doing that. So Sheffield could. And it could say that social care should be a function of neighbourhoods tomorrow. That won't solve all the other problems, but it will make a big difference. I just want to end with one other point before I bring in Cheryl. Anne talked quite rightly about the importance of good residential care, but also asking ourselves what that should be. I've done quite a lot of work in Finland. Finns seem to me to have a really good approach to this, which is that you'd have a residential care home maybe attached to a primary school, because kids and older people could eat together, be together. And I think we really need to make it abhorrent, this kind of privatisation of care. And it's not just the privatisation, which is, of course, an exporting our money into the hands of people who are building really new wave institutions. The average size of residential care units is enormous. But we need to stop exporting our people with the money, sending them out of our communities. If we cannot begin to take seriously the idea of community and neighbourhood without a firm commitment to ensure that really nobody should be asked to leave. We should be organising things at a scale that ensures that people can stay. And only in that way, I think, can we show the commitment we need to show to each other in our need for assistance and for community. So I'm really glad that we've got the range of speakers we have today. We're hoping to take all of the information that comes out of this event and to combine it with the previous event and to start to really develop a kind of manifesto for Sheffield. And I hope we can continue to work with Alexis, who's promised to work with us on making some of this happen now. So, but next I'm honoured to introduce Cheryl Barrett. Cheryl's a wonderful pioneer of work around older people and a great champion of cooperative and community action. So Cheryl, would you like to click your, that's it.
I'm clicked.
Go for it.
Okay, I've got some slides. I'm not sure if they're going to turn up or not. There. Okay, yeah. So as Simon said, I've spent a lot of my time working around age and ageing, and it started when I was an associate director of Better Government for older people. And we were brought together to look at what was called the demographic time bomb. And the idea is that there are fewer people being born, more people being born with what would have been life-limiting conditions, and more people living longer. And that was seen as a demographic time bomb, mostly by the financial people who didn't particularly want to pay pensions or have to give care to disabled people. And what became apparent as we were doing this work was that within the class system, as well as issues around working class, which people sometimes assume has gone away, it's slightly changed, but it's still there. There is the perfect storm in social care of class, gender, women. It's mostly women that are low paid carers because we're expected to do it for nothing. So why should people pay? Older people, disabled people, and Black, Asian, and minority ethnic. Okay, so slide 2, please. As part of this idea of a time bomb, I've got a quote from a lad, Andrew Hankinson. He's angry and unemployed. Baby boomers took all the good jobs, the free education and the cheap housing, left their kids with nothing but the credit crunch and the bill for their pensions. Now, this is not an accident that people think this way. So in order to solve the crisis of care, of health, of economic health, we really need to start looking co-generationally, both nationally and local. Okay, I'm on slide 3. If we go back to the origins of the welfare state, we had the 5 giants on the road to reconstruction after World War II. And this is really the start of the baby boomers. And up to now, we've been mostly working with a cohort that is commonly described as the silent generation. And I think we all are aware that the baby boomers are not going to be silent. But as babies, they were booming, and the government was looking at poverty, disease, ignorance, squalor, and idleness. Okay, I'm on 4. And to defeat these giants, the proposal was to set up a welfare state, social security, national health service, free education, council housing, and full employment. So many of you boomers around here who were in Sheffield at the time of Margaret Thatcher in 1979, you'll observe that it took all of one generation to dismantle this. And Sheffield, if we're looking at local services, then we need to look at what happened to Sheffield in terms of deindustrialisation, of becoming a city with 2 universities and pretty much with a degree engine, but lost generations of people who were not going to become graduates and would finish up in call centres or as very poor care workers. So there's a background to the thinking. I'm on number 5, thank you. What I'm proposing for Sheffield and other localities is the 3 C's of fair care. Now, this concept is about cooperation, and it's not cooperation as most people know it, that there is a legal form, that is a business, and that is a cooperative. I'm looking at the cooperation that naturally occurs. It's human, it's relational, and in terms of care, it's already there. You couldn't have a service as destroyed, as fractured, as awful as our current care service and not have cooperation between the people who are ensuring that this happens. Okay, I'm on number 6. When I was working with BGOT, one of the things that we were looking at was Sherry Armstein's ladder of participation. We're still not there. This was 1969. We did quite a lot of work around this, and I'm sure Sinal will remember when we were advising governments, we were looking at co-production. I'm on slide 7. Slide 7 will show you co-production from Eleanor Ostrom. It was born out of Sherry Armstein's ladder of participation. It's been around since 1971. There are various people looking at it. For me, the missing link for co-production is cooperation. The clue is in the name, it's the co's. So I'm on slide 8. For me, the 3 C's of fair care, the second C is campaign. I've spent an awful lot of time campaigning for a cooperative model, a fair model that involves older people, disabled people, friends, family, lovers, unpaid carers, paid carers, and it needs an agreement. The main cooperation that we need is not the cooperation between the people receiving and delivering care. They're already doing that. It's the cooperation that we need from, and call them what you like, statutory services, social workers, civil servants, politicians, etc., etc. The people who can make the decisions and make things happen or not. What we need is cooperation from those people in order to rethink what is care, how should care be delivered, and what changes do they need to do. And my final C on number 9 is care cooperatives, that we actually do this, that we reform ourselves, that we stop exploitation, which is what care currently is, and we start to look at cooperation. Thank you.
Thanks, Cheryl. You're more than perfect a time. You saved us a minute there. All right, that's brilliant, and we can hear more from you in the panel session at the end. Thank you. Well, next I'd like to welcome David Basu, who can talk to us about some of the realities of providing support services in the city of Sheffield and his experience and perspective on these questions. David, I saw your website recently for your organisation. I was very pleased to see how clearly and well you'd set up the sections on self-directed support. So just from my perspective, kudos to you.
Thanks, Simon. Thank you. Hi, everyone. I'm really interested in what's been said so far, and particularly want to comment later on around neighbourhoods, the benefits of them, but also the risks that a neighbourhood model can deliver in terms of exclusion of particular communities, and also some more conversation around direct payments. But anyway, so we're looking at the new and progressive vision for social care in later life. For those who don't know me, my name's David Basu, and I'm Service Director at SACMA Health and Social Care, which began its life as Sheffield African Caribbean Mental Health Association, but now is an adult social care provider working across all of adult social care. It's a tough time to be active in the adult social care space, and it's a tough time to work in this space, tasked with addressing the challenges we all face as we age and as later life becomes our lived experience. My father, who will be 98 in November, often states, especially when he's in need of support to do something that he previously did without any thought, an old, I think, Caribbean saying, once a man, twice a child. Somebody will correct me if it came from somewhere else. But their sentiment is true. It's tough to be active in this space when you have a focus on home care support, that most vital of supports that has the stated aim of keeping most people in their homes for as long as possible. Adult social care, and particularly domiciliary and residential care for seniors, are probably two of the most heavily regulated and prescribed services in the area of what was called the personal social services. Allied to this, the reward, the remuneration for the staff employed in this area creates some of the lowest paid jobs. I think this notion of unskilled workers in such a regulated industry is beyond me. There are rightly increased and increasing demands with regard to the quality of this provision, but the financial investment from government is woefully inadequate. The fragmented nature of social care for older people means that the challenges of consistency of care and the notion of continuous improvement are notoriously difficult to achieve when we're dealing with hundreds locally and thousands nationally of individual businesses and organisations and charities, all tasked with keeping our elders safe and comfortable and with the ability to still enjoy life. So in this brief presentation, I thought about what I would do, and I was keen to bring alive some of the impacts of the challenges that I've outlined and how they're experienced by individual members of our community who are recipients of adult social care services. And I thought the best way that I could do this would be to share some stories. If I could have the first slide, please, Natalie. No, that's the second slide for the first one, Mr. Gray. That's the one. This may not be what you're expecting, but I think the lived experience speaks volumes. Ernest Gray, or Neddy as he was affectionately called, came to the UK from Jamaica as part of the Windrush generation. And he was married to Rosalind for over 60 years, and they had 7 children plus grandchildren and great-grandchildren. Mr. and Mrs. Gray were seldom seen apart, and they shared a deep and enduring love. The impact of Mrs. Gray's death on Mr. Gray about 18 months before he passed can't be overstated. Mr. Gray died in April 2019, and in his later life, he lived with dementia and other illnesses of old age, illnesses that required him to receive care and support to meet his needs and to support his children as they sought to care for him. Mr. Gray was a plasterer by trade, but in truth, he could turn his hand to pretty much anything, to pretty much any task, and make an excellent job of it. He was a quiet man, a man of few words. I know we don't, this is the language you use now, a term I'm going to share in a moment, and I hope it's taken in the way that I mean it when I say that Mr. Gray was a man's man. I know that's not a term we use now, but I struggle with a different description of him. He was a man of few words, but when he spoke, there was a depth and a wisdom to what he said. He was actively involved with his churches, as were most of his family. He sang in his church choir, and he had a beautiful, beautiful tenor voice. He always looked sharp, always looked sharp, as I think the pictures demonstrate. He took care over how he looked. He was always smart, and his family ensured that this continued even when they had to take pretty much full responsibility for what he wore and when. There were a number of care providers that supported the family, and in truth, it was a challenge. It was a challenge. It was a challenge for the paid carers, and it was a challenge for the family who wanted carers to care as if they weren't being paid for their support. A difficult circle to square, particularly in light of the things that have already been said about reward for this kind of work. Mr. Gray's youngest daughter shared with me the distress that the family faced when it became clear that this particular provider, I'm not going to name names, this is not what this is about, but this particular provider, when dealing with Mr. Gray, simply never spoke to him. Let that just sink in. They never spoke to him. Imagine the situation. Someone is undertaking some of the most intimate and personal aspects of your care, and they simply don't speak to you. You are naked in front of these people, or more than one person, and they simply don't speak to you. You're reliant on this person or these people to be nourished and to be hydrated, and they simply don't speak to you. When the family became aware that this was happening and they raised it with the care staff, the response slayed them. I hope you will find it as shocking as I do. The reason why the carers said they didn't speak to Mr. Gray as they provided his care, and I use the term care loosely, was that he had an accent. He had a Jamaican accent. Just let that sink in. Mr. Gray, who had come to the UK from the Caribbean to help rebuild the UK after the Second World War, and had to navigate his way around Yorkshire accents and Irish accents and Scottish accents. At the end of his life, when he needed care, that care was offered without the semblance of actual care. Can I have the next slide, please? Muriel Basu is my mother. She came to the UK from the beautiful island of St. Kitts and Nevis in 1957 with my two eldest siblings to be reunited with her husband, my father, who came to the UK in 1955. They had 4 more children here in the UK, and when my youngest sister, Angela, started full-time school, Mum gave up her role as a nursing auxiliary, as they were called in those days, I guess a support worker or healthcare assistant in today's terms, and went to Lodgemore Hospital here in Sheffield and began her nurse training. There began a nursing career of some 40 or so years in the NHS, and then a further 10 or 15 years in the private sector after she took early retirement from the NHS. With the exception of her period of training, Mum always worked in what were then called geriatric services, ending her NHS career at St. George's Hospital here in Sheffield, which in those days was called the Geriatric Hospital for the city. Mum was always active. She was always involved in something. She was an amazing cook, a skilled seamstress. She was active in her church, and she was also a singer like Mr. Gray with a beautiful alto voice. In fact, when I was a child, we used to sing together. Mum was a community person. She collected money and she collected food for the miners during the miners' strike in the 80s. And she ran a lunch club for the old people at her church, as she called them, though many who attended the lunch club she ran were younger than her. She was a member of the first Health Watch patient partnership group in Sheffield, and after ending her career in nursing, retrained as an adult literacy tutor teaching English and sewing. In 2009, Mum was diagnosed with a malignant tumour on her liver, but against all odds, she survived. However, she was never quite the same and never really able to do the things she used to do, and increasingly, she needed support at home. My dad is very protective of his mum, his wife, as he calls her. I often have to remind him that his wife is my mother. And he struggled to accept people coming into their home, though he accepted that this was needed to support him and to support us as we cared for Mum and to keep her safe. In 2012, our mum was diagnosed with Alzheimer's and a steady decline began. Again, a number of care agencies were identified to provide support to us as a family. The support provided was of varying quality and varying reliability. I began to learn, I'm a social worker by training, I'm still a registered social worker and practice educator, but I learned the impact of the term time and task. One of the things my father in particular struggled with, though, was the frequent changes in carer. But you know what really grated on him? It was something that really, it was more of a challenge than the unreliability and the varying care. It was usually when some very young carer would appear, often completely unknown to the family, and announce, "Hello, Neville, I'm here to care for Muriel." Now, that might not sound like much of an issue, but let me assure you, in the Caribbean community, little young things, as my parents called them, they simply did not address seniors or big people, as my dad called it, by their first name. Indeed, to do so was the sign of a total lack of respect. My parents were and are proud people, contributing people. As the community developed in Sheffield, they were go-to people for the Caribbean community for many years, and now they were left feeling as if there was a complete breakdown in respect. So why have I shared these stories in an event like this? Well, you'll have heard me use two words in telling these stories: care and respect. And the Accountable Care Partnership in this area, in its 10-year vision, states our partnership vision is for our health and care services to be integrated, joined up, seamless, to reduce and to remove inequalities in health outcomes and access to support by playing our full role as anchor organisations in our city. And to do all this in a way that involves people, their experiences, and our communities at the centre of our work. To do all this in a way that involves people, their experiences, and our communities at the centre of our work. Well, I'd like to add that they need to add two other words to this ambition, a vision that I support, and those words are care and respect. To do all that they're aiming to do, but to do it with care and respect. The situation I shared in telling the stories, there weren't safeguarding issues. Nobody was physically hurt or endangered, but that lack of care, that lack of respect in just two incidents that I shared. And I wish I could say that they were the only two incidents, but they weren't. Highlights the challenge that we all face in this space as we work to achieve a new and progressive vision for social care in later life. The simple application of some of the most basic tenets of person-centered care would have rendered the situations I shared impossible. With Mr. Gray, I'm sorry, I didn't quite get that, Mr. Gray. Could you say it again for me, please? With my mum, hi, I'm here to care for Mrs. Basu. Hello, Mrs. Basu, my name's Lisa. How do you like to be called? What do you like to be called? Simple stuff. Basic stuff. My challenge to the system and to us in the VCF is how do we make this vision? How do we make this vision that I've shared real and meaningful? How do we deliver a partnership vision for our health and care services that is integrated, that removes inequalities in a way that involves people, their experiences, and do all this with care and respect? Can I suggest that a great starting place would be to add in, to embed, to set in the DNA of provider organisations, all organisations, real care and real respect. Thank you, and I look forward to contributing to the conversation later.
Thanks, David. That was incredibly powerful and helpful. Thank you. And now I would like to welcome Alexis Chappell, who heads up the social care services in Sheffield. Alexis is new to this role and has promised that she's really wanting to work with community partners in thinking about the vision for Sheffield. So Alexis, please go ahead.
Okay. Firstly, I'd just like to thank you, Simon and James and team for organising the event today, and also for inviting me along today. So just first of all, I want to start by thanking everybody, and also thank everybody who's listening in today. I'd also like to say I just found that the first and second sessions really powerful, and I'm going to take away a lot from both sessions personally and into the service. I'm very new in post, and what was really important to me when I came into post was to listen and to learn and to look at how I could really work in partnership with everybody I've met so far, and that's always been my absolute commitment. It was really important to me to build relationships so that ultimately I could really focus on working collaboration for the benefit of people and communities across Sheffield. And so what this has really done is by listening to listening and learning has really informed my ambition that to very much enable people to live the life that they want to live in Sheffield, and so that people have positive experience of social care and that feel very much included and connected to their communities. It's really important to me that people have positive experiences of social care, and in particular that we deliver joined up services and solutions, and particularly that people experience services which are accessible and of excellent quality, and that enable people to have good choices, and ultimately from that enable individuals to very much to achieve their personal outcomes. And so, but it's also very important to me that we support our workforce. And I was really taken by David's presentation beforehand, and for me, I think that really talked very much for me about how we very much develop, our workforce, and we value our social care workforce in the city, across all the sectors. And so that to that end, and coming to post, taking forward 4 key developments. First of all, is very much co-producing a strategic plan for adult social care. And to that end, very much working with people who use services or have used services in adult social care in the city, unpaid carers, and also our partners. And so that ultimately we develop a plan that feels right and is right for everybody in the city and for the people and communities of Sheffield. That to me will be the marker that is really that it's a good plan, that it feels right and is right for everybody in the city. And secondly, taking forward what for me, which is a care governance framework, which is about setting some standards and set shared outcomes that, and very much working in partnership again with people who use our services, with citizens of Sheffield and unpaid carers and our partners, so that we very much have a set of outcomes and standards which people could recognise, and that will give very good experiences and enable people to live the life that they want to live. And third, working with partners to develop a workforce plan and social care strategy for the workforce across Sheffield, and that's across all the sectors. And I very much, David's points earlier on were really helpful, and for me, I would really welcome David to be part of the group that takes that forward. And so that ultimately we recognise and support the workforce and social care across the city, and very much through having a really valued and supported workforce, we then deliver excellent quality care for the people in Sheffield. And then fourth, what's really important to me is that we work with partners to look at joined up solutions in communities and across Sheffield. And what's to start off with is very recently we met with Simon Duffy and his team to look at a new model of direct payments, for the city. And for me, I'm really looking forward to what that collaboration will bring, because for me, I really see that as the start of how we move forward together. and that very much we move forward in very tangible ways that ultimately improve the lives and outcomes for people. At the start of this talk, I talked about listening and learning and engaging in conversations. For me, what's really important in going forward and coming into post is that to continue to listen, to learn, and to engage in conversations about how we ultimately deliver and take forward social care services in the city that ultimately will enable and deliver really good services that enable people to achieve their outcomes and that have good positive experiences across the city. And to me, that will be the absolute test of what we've achieved in going forward. So my open invitation is always, if anybody would like to meet with me to talk about their experiences and to talk about how we go forward, I'm very much open to doing that. So I'm going to end there, and then I'm really going to open up for conversations. There was a really good point about making practical solutions, and for me, by co-producing and working together, that's where I'm really keen that we can work together to develop really practical solutions. So I'm going to end there.
Thanks, Alexis. That's great. All right, so you stay with us. Cheryl, join us. David, also join us in this panel. And Alan, you might like to come in too, because you and I are closing the session together at 4 o'clock precisely. So yeah, turn your videos on, Cheryl, Alexis, David, and Alan. Yeah, you two, Alexis, are part of the panel. Okay, and we can, so we were asked to think about a slightly different question. So the first panel were really thinking, I think, in broad policy terms, what should be the priorities. And our second question is a bit different to that. Obviously, there's a connection, but it's, what is your vision for local care services for all communities in Sheffield? And I mean, I don't know, I have no particular right in this matter, but I'd encourage each of us to think about this in as concrete a way as possible, because it's quite easy to say quite worthy things that everybody will nod their heads to. But I suppose my challenge around a lot of this is feeling that it's quite easy for wherever you've arrived at to become the new norm, even if that norm is really unacceptable. And I know a lot of people find my opinions in this field too strong, but I think the social care system is in a really bad place. I have on my, I'm with my mother-in-law at the moment, and we're down in the south of England, but at home in Sheffield, on the library behind me, I have a pamphlet from the Socialist Health Association of Sheffield back from the 1950s. And it's the vision for older care. And this goes back to something that Alan talked about in terms of where the vision was and what Cheryl was talking about. That vision is more progressive than our vision today. That vision, that description of social care in Sheffield in the 1950s is more progressive than where we are today. That's the frightening thing, folks. Like we are like nearly 70 years away from when that leaflet was published, and we've really gone backwards. You know, so it's easy to talk about kind of systems and big words, but I think that it's really important we also start to kind of recalibrate what we think of as normal and acceptable. And I'm gonna pick 2 or 3 little examples of really practical things I think we could do. We can do even with this vicious right-wing government. We can, you know, things we can do even with this madly centralised social care system that we have. So I think one of the things is that in the original vision for self-directed support, and Alexis already touched on this conversation, but the idea was that everybody had a personal budget, and then everybody could figure out what kind of support that they needed. They didn't need to take it as a direct payment. They didn't need to employ personal assistants. Now, somehow, after Ivan Lewis was kicked out of office from the Department of Health in 2008, that vision's disappeared. Residential care homes no longer have to fit within that system for reasons. No explanation, no policy decision was made, but it just started to happen. And local authorities were allowed to realign personal budgets with actually pre-existing community services with no transformational change. Service providers were not trusted to use funding flexibly. Brokers were not used, new community agencies weren't used. Basically, in my opinion, from 2008 onwards, we've made no progress at all in personalisation, in innovation, in creativity using that route. It's an open door for us to go through. We could change the way money arrives in our communities so that it's flexible, it's connected to people, but it also can be managed by support providers or by communities in better ways. We just choose not to do that. So that would be one thing I think we really could do something about now. Second thing I've mentioned already, I think, is that we really could take a map of Sheffield and draw in the 142 neighbourhoods that the people of Sheffield have identified. When you ask them, what neighbourhood are you from, they know the answer. As David says, neighbourhood care might not be a panacea, but for heaven's sake, if we know we're in neighbourhoods, and I know the neighbourhood I'm in, I can act in my neighbourhood, I can be a citizen in my neighbourhood, I can't be a citizen for the whole of Sheffield at that level. So unless you create a framework that people can use, then people just don't have that option. And that is something we could do right now.
Can I just respond to that, Simon?
Of course you could, David.
I think there is merit in the organisation of services and a range of other things along neighbourhood lines. However, I think that model in and of itself, if it's slavishly followed, excludes by default. So I'm Sheffield born and bred, and when I was young, there were 3 or 4 areas of the city that you would find the African Caribbean community. You didn't have to think about it, you would find them there. Scroll forward 40 or so years, and that's not the case. The African Caribbean community is very geographically dispersed. And so it happens in service delivery. It happens in things like the People Keeping Well partnerships. Were we to slavishly follow that neighbourhood model and not have some sophistication around communities of benefit, there are communities like ours, which, depending on whose stats you take, between 9 and 14,000 in the city. I'd really be interested to see what the new census tells us. There are areas where there are not many of us. And so if you're wanting to be, if you're needing to be, wanting to be part of something where there are people that look like you who are delivering services and being recipients of services, to slavishly follow a neighbourhood model builds in the capacity for exclusion. And I think of my own mother in that regard, who, when we started taking her to a daycare setting, a VCF setting, lovely people, brilliant people, but there was nobody who looked like her. And there was an exercise around that they did around D-Day in World War II, and it was very much the White Hills of Dover and Vera Lynn. There was nothing that represented the West Indian Corps, who played a massive part in the war. There was nothing. My mum could relate to that. Her cousin's husband came to the UK to fight in the Second World War. He was pre-Windrush. So I think yes, neighbourhood, and the neighbourhood model is great, and I think there are elements of it that really work, but I think it just needs to be a little bit more agile and a bit more flexible to meet the needs of the range of communities, our community, the Chinese community, smaller communities, but who are nonetheless aging communities.
I have no problem with that. I think Cheryl wants to get in. The only thing I'd add, then, we don't have anything in our neighbourhoods. We're in no danger of being anything like a slavishly following. We have no structures at all.
Yes, absolutely.
You know, so but Cheryl wants to come in.
We don't necessarily have to be one or the other. And I remember David, actually, because I used to be a community worker in Sheffield. I was part of the community work teams. We disbanded them because we had no sense of what needs to happen within communities so that communities can be partners in co-production. We took that away. we could, and I'm a cooperator, so I'm going to go back to my cooperative model. At the moment, we are procuring and looking at private, personal, and public. It is a mess. And for the person who is receiving that care, to navigate the systems that we've got is awful, because we've never looked at care and bottomed it and put in a structure that would allow people to receive care within their neighbourhood. But also, I'm also part of the BAME community. I'm Irish Traveller Heritage. We don't get any care. It's not just whether it's appropriate or not. We just don't get any because we're not considered at all. So if what we did was stop procuring care, took the care budget and co-produced with citizens, to go back to Sherry Armstein and that ladder, at the top of the ladder is that we receive the budget. We get the budget. So that if the local authority, if it redesigned itself and stopped having departments full of department heads and services and in this huge hierarchy, and went across neighbourhoods, facilitating the co-production, we could save some money. We could put the money at the heart of communities. And it's not difficult to think in terms of neighbourhood and in terms of community of interest. It's not difficult at all, but it requires a huge paradigm shift. It also requires that we as citizens, and let's be fair, we're paying for this. It's our taxes that I'm saying we should be redistributing. Our taxes should be coming back to us. So if we think of it as the personal becomes the public when we put our money into a shared kitty, then we work out how we distribute that best. And if people are part of that decision making, they're more likely to want to put more money into that kitty, knowing that what they're putting in, the input, if you like, financial input, means neighbourhoods and communities who are properly supported in a humane way that has the dignity that David is talking about for the person who is receiving care and the person who is delivering care. Because we have taken the human and the public out of the public sector. It's fell apart, it's broken. And I can say this because I am one, tinkering ain't gonna fix this.
Alexis, I know you've got pressure to leave, haven't you? I think you have another meeting that I'm not allowed to go to. But would you like to weigh in on this? Because we've got stuck into some of the meatier side of this debate, haven't we?
Do you know, I've been really, I think it's been a really powerful discussion today, and it's been really helpful to listen to what the experiences are of social care. And I think that's what's been really important today is the listening. One of the things I spoke about is that we are, one of the things I'm really keen that we develop is a strategic plan for adult social care in the city. And to do that, it's really important, you know, that we co-produce this and we have a range of workshops in the city. And I think just listen to what everybody's saying today, I think it'd be really important if you're around that table and being part of the workshops, because I think that ultimately what's really important is that we have an open conversation about how does social care look like in the city and going forward. And that's where for me is the strategic plan is really important, because that's a way of starting to set that out and starting to be really practical about how we take that forward, if that makes sense. And, you know, I think I've asked for colleagues across the VCF to be involved in developing how we both set up the workshops and take that forward. So I'm hoping everybody's been in touch, you know, but ultimately that to me is the way I think would be a good way to work together. You know, and for me it's about the listening exercise, and I've been really taken by what everybody said today. And I think that a really good conversation, and I think a lot of really good ideas. And for me, it's really important to take that on board and to think about how we go forward together, if that makes sense. You know, and I think, you know, I come back to,
sorry.
No, sorry. I'll come back to something that I said earlier on. As I've been a carer as well, as well in my life, and I think that one of the things that's really important to me is people's experiences, and I think it's really important that people have positive experiences of social care, and that social care feels right and is right from their point of view, and for me that's really important. So that's where I'm really keen and committed to working in partnership to find a way forward together. So hopefully that's helpful.
Thank you.
Can I just
go for it, David?
Yeah, so I just really, I'm happy to be part of anything like this, but I think that the conversation that we need to have really needs to be deep and challenging and uncomfortable. And I think one of the points Cheryl made is around tinkering. If it's just going to be around tinkering how we move deck chairs on the Titanic, then it's a waste of everybody's time. We've just been part of contributing to the review of home care that Health Watch were asked to do, and we've been focusing on the African Caribbean community. And some of the people who we approached to be part of this review said, I'm not doing this time. I said, this will be the third or fourth or fifth time that I've been asked these questions, and I can see absolutely no change. I'm not doing it anymore. And so our undertaking is, A, we're going to keep agitated until there is some change, tangible change, and B, if we're asked again and tangible change hasn't appeared, we won't do it, because we've got our credibility to think about as well. And I guess the other thing I'd say is I am a fan of direct payments. I think there are lots of benefits to that approach. However, what Sheffield did at the time of austerity was that on the one hand, it introduced the whole notion of self-directed support, but then allied it to cuts in grants and in funding to VCF organisations, to churches, to all kinds of places that were delivering community-based support. And we were told, certainly our organisation was told, this is how you will generate your income. But the amount that you can earn as an organisation is so minuscule that it cannot support any organisation following that model. So I think this tough conversation we need to have needs to start with the notion that care is not for profit. It's not about money making. It's not about dividends. It's not about all the other stuff that we have got into with this purchaser provider split. But it's about care for citizens who, in the main, and whether they have or not, I'm not getting into the deserving poor, have contributed to their society. So we have got some really deep conversations to have, and I think we're all grown up enough to have those conversations and have them in a really clear way.
Thanks, David. And time's ticking. I'd like to ask, Cheryl came in, but I don't think Cheryl's taken as much time as other people, and she's now the only woman left on this panel. So Cheryl, would you like to just take up that, or you've said something, but maybe you could say a bit more about the next steps for Sheffield you'd like to see, and then we'll go to Alan, and then we'll be able to close for 4 o'clock on the dot, I think, if that's okay. Does that sound okay to you, David, as well? Do you feel like... Yeah. Okay, so Cheryl, then Alan, then I'll close.
I'd like to, I think you know, Simon, that I was part of the team that did the document around alternative economies. And we didn't go as far as we should have. What we should be looking at is old-fashioned cooperation and municipal socialism. And we've got the money in that pool. We need to move right away from procurement, because that's what David was talking about, is this procurement. We need to move away from procurement and look at the budget as a whole for the people of Sheffield, what our needs are, what our capacity is, what have we got that we can build on and strengthen, what is missing. In effect, Sheffield could become its own cooperative, that we don't procure it anymore, but we do redistribute it, we share it, set it up, sheffield.co, and send that money out there. Not as procurement, not as, I'm an old bird, so I remember best value. Of course, we want to have good value. But what we need here is an element of trust, that people can be trusted to identify their own needs, their own aspirations, their own solutions, and to deliver them. And it's a huge paradigm shift. And the other thing we've got to do is we've got to nurture the experts to realise that they don't have to have all the answers. They don't have to hand us the solutions with a package and say, there you go, which again is what David was saying, you know, this is what you can do to make some money. Well, in real time, in real life, no, they couldn't. So can we just move away from all of that? Let's become Sheffield.co, municipal socialists. I'm sure the Greens, the Lib Dems would trip along with us. They're like, fantastic, we've only got one Tory. So why can't we look at this in terms of, and again, agreeing with Simon and David, it's not about making money. Some things are not to be made money. The commodity formerly known as human needs to take their humanity back. I'm all for business, you know. We do need to earn a living, or us that can, but, you know, not everything is a business model. And the business model for care is beyond broken. So why pretend that we can just play around the edges of it? Let's just be, you know, I deliberately use the post-war, Second World War settlement because we're in a post-COVID settlement. How many of those, you know, were out there, the real workers that kept all of this going through COVID, while some of us sat playing on Zoom, you know? Let's start talking to real people in Sheffield and bring us all in together. We are literally all in this together, so we should all have a say. We should all be co-producing. And I agree with the person in chat, Tom, who said, we've hijacked co-production and turned it into something that is obscure and, you know, and a process and task orientated. This is relational. So put the money in the pot and let's start relating.
Thanks, Cheryl. Very powerful. I'll be behind you on the barricades. So I don't think I need to say, but Alan, what's you're connecting the dots for us to the earlier session and just your own personal perception. We've got just 2 or 3 minutes left. What's your view?
First off, Simon, I agree completely with what Cheryl's just said. Absolutely, no question that whatever we do should be co-produced. Looking over the whole of this afternoon's presentations, there's been an absolutely tremendous series of inputs from the basic statistical right through to the personal narratives that David gave us so movingly. So it is amazing the breadth that we've been privileged to witness, and surprising, there's an amazing consensus. I mean, there's also been some incredible contributions in the chat bar, but despite the range, there is an amazing consensus. You know, everyone accepts there's a crisis and the main reasons for that. Everyone accepts there's a need for a radical approach. And what we've heard are basically the core dimensions of a way forward. And for me, and I think most people, the starting point is what Kate said earlier, that care is a fundamental part of the human condition and should be valued as such. And, you know, if we start from that position, then everything begins to take shape and so many different approaches are possible. And Alexis, before she departed, said, it means we have to enable choices. That seems like a trite thing to say, but actually it's hugely radical. Frail older people are not usually associated with making choices. It's, you know, it's what is best for them. But a decision made by a professional, maybe with input from a relative, but putting frail older people at the center of a set of choice-making possibilities is, I find, hugely radical. And then taking on from what David said, he said we need a vision. We need a vision of high quality, integrated, seamless care services that are person-centered and treat people with dignity and respect. And if we start from those points, we will frame an alternative. There's no question about that. The big question is, as he said, can we achieve it? What do we need to do to achieve it in Sheffield and I would say nationally? And I agree with him when he said there can be no tinkering. And with Cheryl also, when she said, we need to trust the people. So I think it's been a tremendous set of presentations, very grateful, and want to thank all of the speakers and those who've contributed to the chat bar as well. We've got a hell of a job to take all of that away and try to frame a summary of it. So that's a challenge for us. But honestly, I think within those presentations and our discussion, there is the basis for a new approach, and it falls to us to try to articulate that. So thanks again.
Thanks, Alan. And it's at 4 o'clock. I mean, this whole concept of It's Our Community is about talking about a new progressive vision for social care. Love it or loathe it, the word progressive was chosen for obvious reasons. We're unlikely to leave our current political difficulties, and obviously I'm not making a party political broadcaster here, but our current political difficulties without cooperation locally and nationally between some of the different parties on the left. And actually what amazes me about the social care challenge is that economically, social care is actually an easy problem to solve. We spend such a small amount of GDP on it that it would be easy to massively improve what we do by just spending a little bit more. And yet somehow social care policy making has continued to track right and follow a pointless drift towards kind of neoliberal austerity economics and all of the assumptions that we've touched on today that have been so damaging over the last 40, 50 years. So obviously Sheffield may not rise to this challenge, but what encourages me about this event, as it did in the previous one, is there are plenty of people in Sheffield with a passionate vision for progressive change who want to move beyond shallow party politics and want to start cracking these problems for real. We've got great partners to this. It's fantastic to have academics come on this journey with us. And given that we've got two amazing universities in this city, as well as a thriving voluntary sector, what can't we achieve really if we just get our act together? That's my final thought. I want to thank everybody who's participated as panelists. I want to thank all the audience. It's great to have you here. We'll be putting all these recordings up online. They'll be available through Festival Debate and the Centre for Welfare Reform. And with Alan and other partners, we will be creating a multimedia kind of record of the kind of key messages that will come out of this project this year. And we'll be taking Alexis up on that offer and trying to make sure that the political structures in Sheffield kind of respond and respect the community voices from Sheffield that we've heard. So thanks everyone. I think I can just say goodbye.
Yeah, goodbye. Bye, Simon.
Bye everyone.
Take care of yourself.